by activity titled Hedgehog Pathway Inhibition for Treatment of Basal Cell Carcinoma. This educational activity is jointly provided by the Postgraduate Institute for Medicine and Access Medical Education. My name is Dr. Alexander Sekulic, and I'm an associate professor and vice chair of the Department of Dermatology and chair of the Cutaneous Oncology Group at Mayo Clinic in Arizona. And I have joining me today Dr. Patricia Lorasso, professor of medicine and associate director of innovative medicine at Yale Cancer Center, and Dr. Bernard Sandak, chair of the Department of Cutaneous Oncology and director of surgical education at H. Lee Moffitt Cancer Center and Research Institute. He's also a professor in the Department of Oncologic Sciences and Surgery at the University of South Florida, Morsani College of Medicine. Our discussion today will include an overview of basal cell carcinoma, basal cell carcinoma treatment options, focusing on surgical and non-surgical options, and as well as the Hedgehog signaling pathway inhibition as a novel model of therapy. We will also review some of the novel emerging uses for Hedgehog pathway inhibition in basal cell carcinoma, and we'll explore many of these issues in form of a case study. The learning objectives for today's activity can be seen on this slide, and Dr. Lorasso will guide us through this.
Thank you, Dr. Sekulic. Just to begin, a brief clinical overview. Basal cell carcinoma is a non-melanoma skin cancer. It's the most common human cancer with an estimated number of over 2 million cases a year. Approximately 80% of all non-melanoma skin cancers are basal cell cancer, and it's the fifth most costly cancer in the Medicare population. Most basal cell cancers are diagnosed early and very effectively treated. There are several risk factors, the two most important, as you can see, being skin color and ultraviolet radiation and ultraviolet exposure. However, there are other risk factors as well, including ionizing radiation exposure, genetic susceptibility, such as Borland syndrome or xeroderma pigmentosum. Immunosuppression is also a risk factor, as well as arsenic exposure. Advanced basal cell carcinoma really comes in two forms. There's the locally advanced basal cell carcinoma, which is local but quite aggressive, and then there is metastatic basal cell carcinoma, which presents at sites distant from where the primary lesion is. Metastatic basal cell carcinoma is uncommon and is estimated to occur, as you can see, in 0.0028 to 0.55% of all basal cell cancers, with the most frequent sites of metastasis being lung, liver, and bone, although it can occur in other places. And the median interval from onset of basal cell lesion to metastasis is approximately 9 years, with a range of 7 to 34 years. There's a historic lack of effective treatment options for patients with advanced basal cell carcinoma.
Thank you, Dr. Lorasso. In light of the spectrum of basal cell carcinoma and risk factors that you just reviewed for us, how do you approach counseling patients about their disease? And I ask in general sense for majority of basal cell carcinoma patients.
Well, first and foremost, I think that, your skin is your largest organ of the body. And I believe that when you do go for your annual physicals, you should make sure that your physician does evaluate your skin for lesions. When you do have a lesion such as basal cell carcinoma or something suspected of such, I think that it's prudent that your physician would send you to a dermatologist so that further intervention, if necessary, can occur, and that you are monitored closely at that point by a dermatologist. Also, in patients, as you get older or you've had a lot of sun exposure, etc., are at increased risk of developing these lesions. And so being that they are at increased risk should caution them more so to make sure that they have a thorough assessment.
Thank you. After this thorough review of basal cell carcinoma, let's move to review of basics of therapy for basal cell carcinoma, and I'll invite Dr. Sandak to guide us through that.
Thank you. I think it's important to begin by stressing that most basal cell carcinomas present early and are treated with localized treatment function. That's what we're aiming for with early detection. Don't want to be treating advanced basal cell cancers if we can avoid it. If we have a localized or early basal cell carcinoma, surgical approaches are most common, and surgery has a high success rate, particularly in uncomplicated cases. This graph shows the different surgical techniques that can be used and their general associated 5-year cure rate. Excision of the tumor is associated with greater than a 98% cure rate. A simpler but slightly less reliable technique for very small basal cell carcinomas is electrodesiccation and curettage, so-called EDC. Cryosurgery in carefully selected patients also has a very good cure rate, and most micrographic surgery is associated with a high cure rate even in basal cell carcinomas that have high-risk features, and that's generally who it's targeted for. Some examples of these high-risk features are particularly critical anatomic areas or lesions that have a large size in a small anatomic area where skin conservation is a primary consideration. The border of the basal cell, those basal cells with a very infiltrated border, are often best managed with most micrographic surgery. Recurrent tumors may be better managed with Mohs, and as well as those occurring in patients with prior radiation to the area or with a history of active immunosuppression. Perineural involvement and certain other histologic features like morpheoform basal cell cancers may also suggest that Mohs micrographic surgery would be the way to go. But if found early enough, all of these surgical treatments should have a high cure rate. Non-surgical treatments are also used primarily for superficial lesions. So we can use topical treatments such as imiquimod and 5-fluorouracil cream, or the topical treatment of superficial basal cell carcinomas, would be much less effective in a nodular invasive lesion. Photodynamic therapy and radiation therapy are also options. You want to think when we're considering radiation about the location, the age, any prior treatments the patient's had, and the patient's genetic background. If a patient is predisposed to multiple basal cell cancers, such as with Borland syndrome, we would consider that not a good candidate for radiation because of the high likelihood of other basal cells developing nearby. Once we get into more advanced basal cell cancers, the historical treatment options we had were relatively unsatisfactory. When there was advanced or metastatic basal cell cancer, there is some historical experience with chemotherapy, particularly with platinum agents as single agents or in combination. As this slide shows, there are anecdotal reports of good responses to chemotherapy, but they were often short-lived and at the expense of a fair amount of toxicity, whether platinum was used alone or platinum was used in combination with other agents, such as doxorubicin. Inhibition of the epidermal growth factor receptor has also been used anecdotally in basal cell carcinoma. EGFR is expressed in over a third of basal cell cancers, and there have been case reports of dramatic responses in patients who, even with refractory disease, with cetuximab. But it's only anecdotal, and it's certainly not something that we can rely on.
Thank you, Dr. Sondag, for this review. And it is clear that for majority of basal cell carcinomas, very well established, simple approaches that may be non-surgical or surgical work well. And as you pointed out, there's a relative lack of data on other treatment options for advanced disease. And this is where one of the most recent and most important advances in basal cell carcinoma has occurred recently. And I will just briefly review this area, which we refer to as Hedgehog signaling pathway, and its role in basal cell carcinoma. This pathway is critical in embryonic development, but it's silenced in most dull tissues, with the exception of a few small compartments where cells are renewed, such as hair, papillae of the tongue, and so on. Mutations in the gene patched, which is one of the key components in this pathway, is identified in Gorlin syndrome in 1996, and subsequent studies have demonstrated that 90% of all basal cell carcinomas have patched mutations, whereas about 10%, remaining 10%, may have mutations in smoothened, which is really the key link in the Hedgehog signaling pathway. Either of these two defects can lead to inappropriate activation of Hedgehog signaling pathway that then drives cancerous phenotype and development. When we look at the Hedgehog signaling pathway, greatly simplified here, we see the smoothened on top, which sends the signal in a constitutive fashion and leads to growth. Patched, binding to smoothened, abrogates the signaling pathway. Smoothened is a key component of this pathway and sends a constitutive signal that drives cell growth. When patched binds to smoothened, this signaling cascade is binding of the extracellular ligands, such as Hedgehog, to patched, relieves this inhibition, and smoothened signaling resumes, and cell growth resumes as well. This type of activation can occur also through mutations, not only binding of the Hedgehog to patched. Thinking logically about blocking this pathway, smoothened emerges as the key component that could be blocked, and indeed this is where most of the developing drugs in this area, including vismodegib and sonidegib, have been directed to. These are direct small molecule smoothened inhibitors. They also lead to abrogation of the signaling and stop the cell growth. Now, when we think about this new advance in understanding basal cell carcinoma, Dr. Morazzo and Dr. Sondak, how do you discuss this with your patients?
Again, start by saying this is not something that we utilize for early basal cell cancers or for ones where a surgical approach, perhaps surgery followed by postoperative radiation, would be feasible. This is something we're selecting for patients with advanced basal cell who have relatively minimal alternative options available. We also discuss with them that this is targeting something that's wrong in the genes of the cancer, not necessarily something that's wrong in their genes, although in the Gorlin syndrome patient that may be not particularly the case, but we're targeting the tumor and that we have a high likelihood of encountering these mutations in the tumor, virtually 100%. And so there's a very high expectation that treatment targeting this pathway is going to be effective, at least initially, and that they may need to be on the drug for a substantial period of time.
Additionally, being a medical oncologist, and Dr. Sondak is a surgeon, when surgery is no longer effective, and some of the other therapeutic options that Dr. Sondak had talked about for local control is no longer effective, we then go to systemic treatment. So one of the things we tell them is, unlike the treatments that Dr. Sondak had discussed, which were local treatments, this is a systemic treatment. So although we are definitely targeting the tumor, there may be other side effects, as we'll be discussing with the clinical trials in the next several minutes, that may ensue because of the systemic nature of the treatment.
Thank you both. Very good points. So both of you mentioned systemic treatments with these types of medications. So let's review the data that we have so far that supports the first structured data that came out really supporting this type of approach was in form of a pivotal trial of the first targeted smoothened inhibitor vismodegib, and this is so-called Aravans BCC trial, which looked at both metastatic basal cell carcinoma patients and locally advanced basal cell carcinoma patients. These patients were enrolled in this phase 2 clinical trial, and treated with vismodegib 150 milligrams daily until they either progressed or encountered intolerable toxicities or with other reasons. Primary endpoint of this study was the objective response rate as measured by an independent review panel. There are several secondary endpoints which are listed on the slide. The key patient eligibility criteria are listed on this slide, and I will draw your attention mainly to the second half of this slide where patients with locally advanced BCC are described. And I do so mainly because this was the first time where this term of locally advanced basal cell carcinoma was defined specifically for the purpose of the enrollment in this trial. This patient had to have at least one lesion with the longest diameter of 10 millimeters or greater, which was considered either inoperable or for which surgery was considered inappropriate. These patients have typically recurred after 2 or more surgical attempts. Also, prior radiation therapy to 1 or more target lesions was required unless there was medical contraindication or radiation therapy was felt to be inappropriate. The findings of this trial were published in New England Journal of Medicine in 2012 and briefly demonstrated the response rate for metastatic basal cell carcinoma cohort at 30% and local advanced basal cell carcinoma at 43%. If we look at the waterfall plots from this study with metastatic basal cell carcinoma on the left side and local advanced basal cell carcinoma on the right side, each bar representing a patient and deflection downward indicating shrinking of the diameter of the tumor, upward increase in the diameter, we can very easily see that a vast majority of patients had some level of tumor shrinking. In locally advanced basal cell carcinoma, that was more pronounced with complete responders clustering on the right side of the diagram. The median duration of the response at the time of the primary data analysis was 7.6 months for both cohorts. The several subsequent slides here will illustrate some of the responses, and you see here a large tumor on the left angle of the jaw, which was treated, and photographs at 32 weeks shows resolution of the tumor. Biopsy at 24 weeks shows no residual BCC, and this was a scouting biopsy. However, this treatment did leave a scar-like area. The patient with large lesion on the scalp, which again is followed here from baseline to week 8 and week 20, and biopsy, scouting biopsy, and this patient presented with multiple primary independent BCCs, several which are shown here, and you can see the top two in the right preauricular area and the posterior neck, completely resolving by week 24 with no residual BCC and scouting biopsy, and then a large lesion, which was the primary target lesion for this patient, involving the temple and obliterating the external auditory canal, which at 24 weeks has significantly improved, but you still see few areas that have not completely reepithelialized, and those did show residual BCC at 24-week scouting biopsy. With longer follow-up, we can better assess the duration of the response in this patient cohort, and I will only draw your attention to the numbers in the red highlighted boxes, which show an increase in duration of the response, specifically in the locally advanced basal cell carcinoma cohort, from 7.6 months at the time of the primary analysis to 26.2 months at the 30-month analysis, indicating that a subset of patients are indeed having durable response. Following two slides illustrate median progression-free survival at the time of the final update at 30 months, again indicating better survival in patients with locally advanced BCC as compared to metastatic BCC here, which is good. Investigator-assessed median overall survival is shown here again at the time of final data update at 30 months, showing again that overall survival is significantly different between the two groups as expected, consistent with previous observation of metastatic basal cell carcinoma being significantly more aggressive disease. Now that we have reviewed the data supporting the efficacy of vismodegib It is important also to look at the toxicities of this therapy. Here we have a table listing all adverse events noted in this trial that are occurring at frequency greater than 20%. And you can see that there's several events here listed, and most prominent ones are highlighted in red, including muscle spasms, alopecia or hair loss, and dysgeusia or ageusia, indicating changes in taste, alterations of taste, or lack of taste. These are very frequent events, as you can see, and if we look at the grade of adverse events, the vast majority of adverse events were mild to moderate, in the mild to moderate range. Second study that has contributed data to this field is a study of sonidegib, also known as LDE-225, called BOLT study, also a pivotal study, phase 2 clinical trial, and I will invite Dr. LaRusso to walk us through the data from this study.
Thank you very much, Dr. Sokolek. The BOLD study, as Dr. Sokolek said, involves the use of a single drug, LDE-225, which is also a drug that targets the Hedgehog pathway, very similar to vismodegib. In this trial, the patient population that was enrolled was also either locally advanced breast cancer or locally advanced basal cell cancer or advanced metastatic basal cell cancer. And in this trial, the treatment involved stratification of a 1-to-2 randomization of 2 different doses of the same drug, either 200 milligrams of sonidegib or 800 milligrams of the drug. And these patients were treated, just like in the other trial, to either disease progression, unacceptable toxicity or death, or discontinuation for any other reason. They were followed, as you can see here, and long-term they were assessed whenever possible for survival. Again, as you see here, we have waterfall plots very similar to those that were presented in the previous study. And in these waterfall plots, we look at maximum tumor decrease, again, in both the locally advanced cohort as well as the metastatic basal cell cohort. This slide is a central review at the lower dose of 200 milligrams daily with, as you can see here, 50 plus patients in the locally advanced and 12 in the metastatic basal cell cohort. Again, showing that the vast majority of patients with locally advanced had a response based on the lines on the bottom portion of the line in the waterfall plot. And in the metastatic patient population, the majority of patients also had a response. As you can see in the locally advanced, there were several patients that had significant partial responses or complete responses. And in the metastatic patients, there were 2 patients that had at least a 50% decrease, with the vast majority of other patients having decreases but not meeting criteria for response. Looking at the, again, objective response rates, again, central review with the primary efficacy analysis, looking now at both the 200 milligram and the 800 milligram daily dose of sonidegib. The proportion of patients with objective response is in the top line, and in both the 200 and 800 milligram dose, there was really no difference in objective response, being 43% with 200 milligrams and 38% with 800 milligrams in the locally advanced cohort. And we see the same pattern again in the metastatic basal cell carcinoma cohort, being roughly 15 to 17%. The total overall response rate, regardless of dose, again, was very similar, 36 and 34%, with only 2 complete responses in the entire trial, and that was in the locally advanced 200 milligram cohort. And as you can see here, partial responses. The bottom line of this trial is that regardless of whether or not the patients got 200 or 800 milligrams, the response rates appeared to be very similar. Looking at the side effects, again, similar to the vismodegib study or the Aravan study, because the side effects tend to be pathway specific. Muscle spasms, alopecia, dysgeusia were the most common. And in this study, there was also a CK increase, but there was no cardiac CKMV. This was just CK increase as well, possibly going along with the symptoms of muscle spasm. And if you look at both cohorts, both the 200 and 800 milligram cohorts, there may have been slightly more toxicity in the 800 milligram than the 200 milligram cohorts. But again, no increase in efficacy with increase of the dose. So sonidegib was FDA approved, as you can see, in July of 2015 for the treatment of adult patients with locally advanced basal cell cancer that had recurred following surgery or radiation, or those who were not candidates for surgery or radiation therapy. Its approval was based on demonstration of durable objective responses in patients with locally advanced basal cell as determined by the Central Independent Review according to a modification of RECIST. The overall response rate for the 66 patients with locally advanced disease randomized to the 200 milligram arm was 58%, consisting of 3 complete responses and 35 partial responses. In terms of Hedgehog pathway inhibition in basal cell carcinoma nevus syndrome or Gorlin syndrome, these drugs have been investigated. The first study was with, as you can see here, vismodegib versus placebo in this patient population. And these patients were given 150 milligrams a day for 18 months, then treatment was discontinued, or placebo. And the randomization was 2-to-1, vismodegib versus placebo. And in the placebo arm, there was open label continuation of vismodegib potentially for, again, 18 months if these patients progressed, and then they were then monitored for 6 months. The primary endpoint was determination of efficacy in reducing new surgically eligible basal cell carcinomas, as well as safety, with secondary endpoints being efficacy in reducing the number of basal cells on the upper back and duration of any anti-basal cell carcinoma effect after administration of the drug was discontinued. As you can see here, this is a surgically eligible basal cell in one of these patients, and this is the vismodegib response, quite profound as you can see here on the back. But you also see evidence between baseline and 5 months of significant improvement on the face as well. Significant marcation, as you can see on the left-hand side of the upper back lesions, with significant improvement in the majority of the lesions. And in the face, there was significant improvement in all of the lesions in this patient with basal cell carcinoma nevus syndrome. This is just looking at the results in 36 patients, followed by more than 2 additional months according to the study group. And these patients were surgically eligible basal cell carcinomas. Dr. Sondek or Dr. Sekulek, you may want to comment on this, but what we see is, as you can see, significant effects with vismodegib relative to placebo in each of these. If you do a comparative of A, B, and CD, significant benefit with the therapeutic intervention relative to the placebo control arm.
I very much agree, and I think it is also very important to highlight that this treatment is not only decreasing the size of the existing basal cell carcinomas, as it's shown in panel C in actively treated patients versus placebo in panel D, but also it prevents onset or development of new basal cell carcinoma, surgically eligible basal cell carcinomas, as seen in panel A in treated patients compared to placebo in panel B. And admittedly, this may be somewhat unique, as these patients that have genetic susceptibility for development of multiple
pathway inhibition in these patients with basal cell carcinoma nevus syndrome is multiple. Dr. Sondak may want to comment on the surgical, but it's typically individual basal cell carcinomas may be operable. The intensity, the multiplicity makes surgery, however, challenging as they continuously, in these patients with Gorlins or the basal cell carcinoma nevus syndrome, continuously develop these lesions, and so continuously operating on them, especially in select areas that are challenging, such as around the orbit or around some of the other structures within the face and other areas of the body, makes it extremely challenging after a certain period of time. There can be topical and photodynamic therapy used, but these treatments really have only shown partial efficacy, and they typically can only be used, well, they can be used for many different lesions, but they're usually only efficacious if they start treating very early lesions. And then, as discussed in the previous few slides, systemic hedgehog pathway inhibition has dramatic impact, not only in shrinking existing lesions, but in the prevention of new lesions. However, because it is systemic treatment and it is targeting this pathway, side effects tend to be an issue with lifelong need, and long-term efficacy has not been made clear as yet because of the duration of time that some of these patients have currently been followed on study.
Thank you, Dr. LaRusso. This is a great overview of basal cell nevus syndrome. We have talked about two smoothen inhibitors, but there are other drugs that are in development in this area, and this table lists several agents that are in various stages of evaluation, some of them being similar in their mechanism of action to vismodegib and sonidegib, and some acting at other points in the Hedgehog signaling pathway. Given the data that we have just reviewed in terms of efficacy of these novel treatments as well as toxicities that occur with therapy, Dr. Sondak, what would you list as the key point that you try to convey to your patients when trying to make a decision between therapy and systemic therapy such as vismodegib or sonidegib?
So we always try to use surgical therapy, a localized therapy, surgery with radiation, if we possibly can, to avoid the need for long-term systemic treatment with its attendant side effects. But there are many situations in which we simply can't do that, or where systemic therapy would be clearly preferred. Importantly, there are occasional scenarios where a tumor that is completely unresectable by any standard criteria can be rendered resectable with a course of systemic therapy with a Hedgehog inhibitor. And this is an evolving area that hasn't been studied in prospective trials, of which we are seeing on occasion more and more. We're getting questions from individual patients and even from physicians. Which of these two Hedgehog inhibitors should I use? And so far, there's not any comparative data. There's no head-to-head data that says drug A is better than drug B or vice versa. I would point out that when one is comparing the data from the two trials, the original trial that resulted in the approval of vismodegib, which is called the Aravance trial, and the newer trial that resulted in the approval of Hedgehog, which is called the Bolt trial, that the evaluation criteria were subtly but significantly different between the two studies. And most importantly, they differed in how a complete response to therapy was defined. So when somebody is looking at the data, it's important to note that you can't really put them one next to the other and say, oh, this is slightly better for this one, so I'll use that. I think individual physicians are going to have to develop their own comfort level with these drugs. We see much more similarity than difference between the drugs. And I think it's important to get familiar with one or the other and use it on an ongoing basis to have the best results. I don't think we're going to see too many situations where we say, oh, I've got to use this drug because the patient had a problem with that drug. And likewise, I don't think we're going to see too many situations where if the tumor doesn't respond to one of the drugs, it responds to the other.
Thank you, Dr. Sondak. At this point, we will turn to a case study which we will discuss as a way to illustrate some of the points that we presented in earlier slides in more of a functional way with decision-making points. So we're presenting here a case of a 71-year-old woman with a several-year history of an enlarging ulcer on the right side of the head. She seeks medical attention prompted by family due to fatigue and facial paralysis. On this slide, you see a large ulceration involving most of her right head with complete destruction of the ear. She also has right-sided paresis. There is also visible right neck lymph node highlighted by the arrow. Biopsy of the large ulcerated lesion confirms diagnosis of basal cell carcinoma. How would you treat this patient at this point? We have several options here. Perform excision, refer for Mohs or surgical oncologist evaluation by head and neck surgeon, obtain imaging studies to investigate involvement of deep structures, or refer to radiation oncologists for consideration of radiation therapy. I'll invite Dr. Sondak to comment on this first.
Thank you. This is clearly a case with an unresectable tumor, very locally advanced, a lot of destruction of important structures. We would not consider this patient for a primary surgical approach, even with Mohs surgery or otherwise. This is an ideal patient to begin the evaluation process for consideration of systemic therapy with a Hedgehog inhibitor, and therefore, I believe the correct answer is 3. Obtain imaging studies to investigate involvement of deep structures and to provide a baseline for follow-up as we utilize systemic Hedgehog inhibition.
I agree. Very important to know the full extent of disease. And if we look at this following slide, imaging has really provided significant and valuable information. In this case, this patient did have CT and MRI, which showed destruction of soft tissues, as well as the right temporal bone, erosion of the right EAC, and middle ear ossicles. Right middle ear cavity was completely involved and opacified. Dural involvement was very obvious, but brain parenchyma was felt not to be involved on the CT scan, as illustrated extensive local disease. Regional nodal metastases that were also seen on physical examination were confirmed. No further distant metastases were seen. So at this stage, what is the most appropriate next step? 1, resect as much as possible, followed by radiation. 2, radiation only. 3, Mohs surgery to ensure clear margin. Or 4, consider systemic therapy. Dr. Sondak, you already mentioned this is an advanced case where you would consider systemic therapy. Would the imaging in this case sway you one way or the other?
I believe the imaging in this case supports that this is an unresectable lesion with extensive destruction of the underlying tissue, and this is absolutely an ideal case to consider systemic therapy.
Very good. So this patient did undergo multidisciplinary evaluation, and surgery was felt not to be likely to obtain clear margin by the multidisciplinary group. Radiation was considered possible, but significant challenges were anticipated given the location and the extent of the disease, as Dr. Sondak pointed out. Patient was then initiated on vismodegib therapy. This also, I think, illustrates the importance of this multidisciplinary evaluation in many of the patients that have this type of challenging disease. After 4 months of treatment of vismodegib, while still on therapy, photographs are provided here. Dramatic shrinking of the visible tumor was noted. Enlarged lymph nodes were not visible anymore, and the area of the tumor continued to re-epithelialize. And again, this is a photograph at 4 months. So with significant response, patient is very happy with her progress, but is struggling with increasing side effects, particularly muscle cramps. What would you do at this point? One, tell her muscle cramps are common, and we should encourage her just to continue through this. Stop therapy as muscle damage can lead to renal failure. 3, encourage hydration, electrolytes, and consider muscle relaxants. 4, switch to sonidegib with the hope of having less side effects.
In this case, we would definitely take these muscle cramps seriously, not tell the patient to power through them. Quite the opposite. If we need the patient to stay on this drug long term, so we want to find a solution to this problem. Switching to another hedgehog inhibitor is not likely to ameliorate the problem. So we do have to recognize that we don't have to stop the therapy completely, that we can manage this in a graded fashion, and we would start with encouraging hydration, electrolytes, and muscle relaxants, and also consider a drug holiday to get this under control, at which time we can usually reintroduce therapy successfully later on.
So as Dr. Sondak suggested, this patient did have treatment for her muscle cramps with hydration, with electrolytes, and with muscle relaxants. And this is an approach that is effective in a subset of patients, but not in all patients, sometimes requiring drug holiday, as Dr. Sondak pointed out. Weight loss, listed here in the middle of the slide, is another issue that these patients may face. As we mentioned earlier, loss of taste or alterations of taste can often lead to decreased intake, both liquid as well as caloric. So it is important to ensure adequate caloric intake. So in this case, with aggressive hydration and electrolyte replacement, this patient did show significant improvement in muscle cramps, and addition of cyclobenzaprine, even small dose of 5 milligrams at night, further helped reducing her muscle cramps. Interestingly, this patient stated that tonic water also helped with her cramps. And this remedy has been noted for many years as possibly effective for muscle cramps, but there's really limited literature support for this, so it's really challenging to provide a conclusive recommendation regarding that. Patient also pursued controlled caloric intake, which has been very effective in her case, and she gained 16 pounds in 4 months. Importantly, also, her hemoglobin has improved as the bleeding from the lesion stopped, and her hemoglobin increased from 7.7 at presentation to 10.9 at 4 months. Dr. LaRusso, we have talked about management of side effects in terms of muscle cramps. Any other thoughts in terms of overall side effects with these types of medications when you are counseling your patients?
No, I think you brought up one important side effect that we really didn't go into in great detail, but has downstream repercussions, and that's the dysgeusia. These patients can have such an altered taste that they totally lose the craving to eat. Food just has no taste at all. And that is the most likely cause of this woman's weight loss. So as soon as we see that side effect, we have to encourage them to, to try to use alternative sources of calories, such as this woman who used Ensure, to be able to prevent significant weight loss from occurring. Because I find that it is very, very common. The longer that they're on the drug, the more common that this is a long-term side effect.
Thank you. Those are very good points. And I think it also may be important to highlight that many patients will have a question regarding the duration of side effects if they should get off therapy. And I think it's very safe to state with all the experience so far that side effects that we have discussed are reversible. And that I think can be very encouraging for the patients. So if this patient continues to respond and her wound heals fully, how would you manage the patient at this point? One, stop vismodegib and observe. Two, stop vismodegib and perform adjuvant radiation. Three, repeat imaging to assess disease extent. Or four, continue treatment to prevent relapse and resistance. Dr. LaRusso, what would be your approach in this case?
Because this patient has been on vismodegib for a prolonged period of time, it's imperative that you follow these patients routinely to see how their disease continues to respond. And because she had deep-seated lesion on the CT scan, I think at this point it is important to repeat her imaging to see if the disease remains under control or if it is beginning to grow again.
Very well. If the patient now, after having a very clear response, experiences disease progression, which will be consistent with resistance, while receiving therapy, which of the following is most likely explanation for her progression? One, the therapy has converted the tumor to an SCC, which does not respond to the drug. Two, the tumor does not require Hedgehog pathway signaling any longer. Three, additional mutations may have occurred in smoothens. And four, metabolism of the drug has increased, leading to subtherapeutic blood levels.
This scenario lends itself to number three, foil number three. Many times with prolonged administration of many of the small molecules that target specific pathways, and in particular vismodegib in this case, targeting the Hedgehog pathways, with long-term drug administration, additional mutations can occur in the pathway, and that's the most likely cause of disease progression in this woman.
Very good point, and I think also it is worth noting that some recent publications indicate that specifically in basal cell carcinoma, there may be one more level of complexity, implying that there may be pre-existing mutations in small populations of cells within the cancer that over time then will outgrow and mediate clinical resistance. Several other points that were raised here, such as basal cell carcinoma converting to a squamous cell carcinoma, there is some evidence in literature that squamous cell carcinomas can occur in patients treated with vismodegib, but there is really no clear data yet to indicate that this is a common problem. Metabolism of the drug, as suggested in number four, typically is not increased, and this would not explain the. As we just discussed, most common events leading to resistance are smoothing inhibitors are smoothing mutations, first noticed in medulloblastoma, a type of cancer that also frequently carries mutations in Hedgehog signaling pathway, and subsequently in basal cell carcinoma, as we have just discussed, both as primary resistance as well as secondary resistance developing while patient is on therapy. In addition to smoothing mutations, alterations in various other components of the Hedgehog signaling pathway can lead and have been shown to be capable of leading to resistance, but also upregulation of other pathways can compensate for the inhibition of Hedgehog signaling pathway, and here we see IGF receptor being activated in an autocrine fashion, leading to cellular signaling through PA3 kinase mechanisms and AKT, and adding a proliferative signal leading to survival and growth of these cancers. One emerging area, as Dr. Sandak pointed out earlier in our discussion, is potential use of smoothing inhibitors or Hedgehog pathway inhibitors in scenarios that are beyond locally advanced or metastatic basal cell carcinoma. And this is an active area of interest and exploration, and this can be described as neoadjuvant treatment, where the goal is to really shrink the tumor prior to the main therapy, in this case, most likely surgery. The The data for this is very limited. There is one investigator-initiated open-label trial that was published where neoadjuvant treatment with vismodegib was tested in its ability to reduce the estimated surgical defect for large basal cell carcinoma. This is a small study of only 15 patients, and among those 15 patients that have had 2 to 4 months of vismodegib, followed by Mohs excision, patients that completed at least 3 months, which was 9 patients, had 31% decrease in anticipated surgical defect. Again, small study, we need larger numbers, we need more data to really estimate the efficacy of this approach. But most importantly, I think, what we still are lacking in this field is the data to really determine whether drug therapy will shrink the tumor contiguously or will it break it into multiple pieces. This is an important issue as many of these cancers are being treated by Mohs surgery, and Mohs surgery, as you know, relies on microscopic control of the margins with the assumption that once the margin is clear, there's nothing beyond the margin. Again, relying on the contiguous nature of the tumor. And so whether the contiguous nature of the tumor remains on therapy has not been fully evaluated today. So this is the type of data that will be needed before we recommend full neoadjuvant treatment. So the key takeaways from today's activities are as follows. Hedgehog pathway inhibition is an effective treatment for locally advanced or metastatic basal cell carcinoma, where historically we have initially mentioned were very few treatment options. Multidisciplinary management is encouraged for many of these patients, as broad areas of expertise are needed to fully evaluate these patients. Utility beyond advanced basal cell carcinoma is being explored. We've gone through some data from basal cell nevus syndrome patients, which is very encouraging and really life-changing for many of these patients. And we've just talked about neoadjuvant therapy, which is a very interesting and attractive option, but more data is needed. And finally, side effects can be very challenging for some patients, requiring remission, but also active management and occasionally drug holidays.
Dr. Sekulek, that was an outstanding review of the Hedgehog pathway and basal cell carcinoma. There are many patients that are affected with this disease, and there are organizations now that are moving at the forefront to try to help these patients and help scientists in their quest for improving outcomes and clinicians for their quest in improving outcomes for these patients. One such foundation is the Skin Cancer Foundation. But there are also advocacy groups, Dr. Sekulek, that I think we need to, and advocacy resources that we need to keep in mind when counseling these patients and when helping them, because many of these resources that are available may come in handy for the patient for many different types of resources and knowledge that they would need. Listed on this slide are a few of those, but people are making a concerted effort and organizations as well to help these patients, because up till recently, when the disease was more advanced locally as well as metastatic, there were no treatment options. And even with just locally advanced disease, the morbidity and the outcome for these patients, unfortunately, can be devastating. So I urge you to refer your patients to some of these resources to assist them in helping them cope with their disease.
With this, we'll conclude today's activity, and I would really like to thank both Dr. Marusa and Dr. Sondak for joining me today. Thank you very much.